Hi, it's June 17th, 2016, and this is the RheumNow Week in Review. I'm Jack Cush, Executive Editor of RheumNow.com, with news and information from the last 2 weeks. That includes EULAR, a very interesting meeting. I'll start off with some basic teaching points. One, tophaceous gout generally doesn't occur until we've had 10 years of disease activity. The tophi can be found over the ear, the helix of the ear, fingers, toes, wrists, knees, olecranon, Achilles, and even the sclera, heart valves, strange places. New imaging techniques can pick up tophaceous deposits throughout the body. A recent review article that you can find on the website reminds us that varicella reactivation not only causes shingles, but may lead to vascular inflammation and a number of different events that may include meningoencephalitis, myelitis, vasculopathy, strokes, giant cell arteritis, and cerebral aneurysms. Again, is it implicated in the etiology of those conditions remains to be seen. The FDA has issued a warning that over-the-counter medicines like Alka-Seltzer, Bromo-Seltzer that contain aspirin may be associated with an increased risk of bleeding. A report showed that MRIs done in 196 normal individuals was associated with very few patients having a totally normal MRI of the hands. In fact, they found over 70% of patients had abnormalities, including erosions, suggesting that we need to be careful about overinterpretation of the MRIs. Secukinumab data was presented at EULAR, and Novartis has announced that it's going forward with a head-to-head study of secukinumab against adalimumab in patients with psoriatic arthritis. We'll look forward to that report. Other news items this week, a journal report from a UK clinical database of millions of people in the United Kingdom looked at 528,000 statin users, of whom 1,357 patients developed new onset rheumatoid arthritis. They showed that the ability of statins to reduce the risk of rheumatoid arthritis is only seen with high intensity, meaning high dose statin use, and that was only in comparison to those that were on low dose or low intensity statins. Again, thus far, the clinical trials have not been able to show us a reduced risk of RA or a true anti-inflammatory potential for this drug, the statin class, but nonetheless it's interesting information. Another report looked at the association of renal disease and allopurinol use, specifically looking at very low doses of allopurinol versus very high doses or normal doses of allopurinol. And using a claims database, I believe it was Medicare patients, compared to patients who are on very low dose, those who are on 300 milligrams or higher had a reduced risk of developing end-stage renal disease and acute renal syndromes, including renal failure, showing that, again, more aggressive use of allopurinol needs to be considered. And it was not only just the dose, but also the duration of use. A Swedish registry at EULAR looked at the association between lupus and cervical cancer, and specifically found a twofold increased risk of cervical dysplasia and cervical cancer amongst lupus patients. Another report showed that half of RA women and 1/3 of men with rheumatoid arthritis admit to having no sex at all, and that when questioned further, at least 1/3 of both men and women had reports of sexual dysfunction that was related possibly to their disease and or their medications. A report from EULAR showed that smoking and obesity reduced the odds of treatment success in early RA, data from an early rheumatoid arthritis population in Canada. More reports from EULAR. EULAR showed that a very interesting report of a large cohort of systemic sclerosis patients showed the ability to predict mortality in patients with scleroderma based on 5 factors for which you develop a score that include being male, upper GI involvement, proteinuria, LV function, left ventricular ejection fraction being less than 50%, and DLCO being less than 60%. Again, a very interesting abstract, OP0030, talked about how you could develop a score. The CATCH study, another early RA study from Canada, showed that a delay in biologic starts could be seen in those who had received subcutaneous methotrexate, also in those who were elderly and those who had a low DAS. But the idea of maybe more aggressive methotrexate through subcutaneous administration may result in a delay in the use. A very hotly contested item at EULAR was the issue of Humira versus Cosentyx indirect comparison studies. There was actually an abstract by both companies, AbbVie and Novartis, that showed that you could make these indirect comparisons and make a case for either drug being superior to the other. The audience and physicians in attendance were generally not in favor of such comparisons, instead want to look forward not to these statistical manipulations, but rather true head-to-head studies to come up with a real risk of developing or showing success with one therapy or another. Again, another EULAR highlight was the Prairie study. The Prairie study was a study that looked at the use of rituximab, a single infusion, 1,000 milligrams given to patients with preclinical rheumatoid arthritis, meaning they did not have rheumatoid arthritis, but yet they had seropositivity with rheumatoid factor and ACPA positivity, and evidence of arthralgia. They also needed evidence of either an elevated CRP, marginally so, or imaging evidence of synovitis by MR or ultrasound. And they showed that if you gave 1,000 milligrams to 40 patients compared to 40 who got placebo, you could delay the onset of arthritis at 12 and 18 months by as much as 50%. Again, this is an important study because it's the first to look at preclinical treatment with an immunosuppressive agent, and it is being repeated in other studies. So we'll look forward to more preclinical trials to tell us more about whether we should be treating such patients. However, there are questions on the website about how would I use this in treating patients, and I said I would not. This is an experimental trial under very controlled situations. Patients who don't have rheumatoid arthritis shouldn't receive medicines for rheumatoid arthritis, so they need to meet criteria before one instills therapy, including rituximab. Again, we await more research on this area. And a very important study that came out in the news but not presented at EULAR was GIACTA. GIACTA is the first double-blind, randomized, placebo-controlled trial of tocilizumab in patients with giant cell arteritis. The company released a press release, and it was put out there that, again, patients who received tocilizumab met the primary endpoint of sustained remission and better steroid tapering. I assume that the full report will follow at this year's ACR meeting. A last few bit of publications that appeared in journals. In Annals of Rheumatic Disease this week, 11 European registries showed that there was no association between biologic use and the development of invasive or malignant melanoma. This is an interesting study because it's a very hard issue to look at. As you know, there is no risk for solid tumors with biologic use. In fact, the ACR guidelines say that if a patient has a solid tumor or a history of solid tumor, you should treat them as if they didn't have the tumor at all. And that's in the guidelines that were just published. But there is concern about lymphoproliferative disorders and a few other cancers, but especially melanoma, which there isn't a lot of data. So 9 countries, 11 European registries pooled all their data, over 130,000 rheumatoid arthritis patients, looking at the risk of first invasive melanoma, and showed that if you're on a DMARD, not on a biologic, just on a DMARD, your SIR, or your risk, was 1.1. If you were on a TNF inhibitor, your risk was 1.2. That was the SIR. And if you're on rituximab, it was 1.3. And all these had confidence intervals that overlapped 1, saying there was no increased incidence of melanoma. So that should be comforting to those considering that issue. However, many of us want to know if you have a past history of invasive melanoma, malignant melanoma, what do you do? Again, that issue is not studied here. You should also know that this did not look at melanoma in situ, which has little or no risk of recurrence and shouldn't sway your decision making regarding treatment and biologics. A report presented at EULAR looked retrospectively at the secukinumab or Cosentyx drug development experience, and specifically looking at